Hi, everyone. My name is Cameron Gutbarth, and I'm a recent graduate of Barnes-Simmons. I majored in biology and minored in biochemistry and honors, and I'll be attending medical school next fall. I started this presentation as my honors capstone during my senior year at Barnes-Simmons with the help of Dr. Eames. As a future healthcare provider like yourselves, I wanted to get an overarching picture of what the healthcare system in America looks like and how I'd fit into it. So Dr. Eames then got me into contact with Professor Clay, and we decided to split up my capstone into 3 presentations for this health policy and billings class. So that's a little bit about who I am and what this is for. And here's part 1 of 3, summarizing healthcare in America. So this is an overview of all 3 presentations. We'll cover a brief history of healthcare and insurance in part 1. Then we'll evaluate our current system in part 2 in terms of quality, cost, and access to healthcare. In part 3, we will critically analyze some attempted solutions to our current problems and some trends in healthcare. You'll likely cover more in your class, but the goal is that this will be a good introduction to the material, especially since a lot of my information comes from your textbook, Understanding Health Policy by Bodenheimer and Grumbach. So heads up, there will be a multiple choice quiz with questions and answers from these presentations. I will also include some open-ended questions during the presentation. You will probably not be graded by those, but they're good things to keep in mind. So look forward to that. If you have a notebook, it might be good to take some notes and jot down your initial answers to those open-ended questions. So the goals, these were the original goals of my capstone: to be edifying and educational and to promote empathy. So I feel like they're worth mentioning given the nature of healthcare and politics. My goal is not to change your mind, but to help you think from others' points of views. I also hope that you will get an accurate snapshot of our current healthcare system, as well as a sufficient historical context to inform your votes, conversations, and understanding of newsworthy developments. Beyond mere facts, I hope you also learn some empathy concerning those for whom the healthcare system in America does not work very well. Of course, I need to secure some grace for myself when approaching such a controversial topic, so here's just a minor disclaimer. These short presentations are not nearly enough to adequately educate anyone on all the political and medical concerns related to healthcare systems in America. And it's likely that you will have knowledge, experience, and opinions that would have added much to this presentation if only it were more of a discourse than an exposition. I hope that this presentation does lead to many productive conversations and discussions, and I'm glad you get to cover this content with more direction from Professor Clay. So healthcare in America is a controversial topic, as it should be. One of the striking qualities of medicine is that it cuts to the heart of everyone's lives: birth, death, diet, lifestyle, sex, income, abuse. A change in the healthcare system can impact any one of these factors in a person and society. Healthcare matters, so it's only natural that the topic is accompanied by deep and strong emotions. With that said, I hope to do the topic justice without walking on eggshells or stepping on toes. So without further ado, let's get started. So part 1, a brief history. We'll cover out-of-pocket, the rise of insurance, and government involvement. So these are primarily financial ways of looking at the history of medicine in America. So I like this quote from the textbook: "Healthcare financing in the United States evolved to its current state through a series of social interventions. Each intervention solved a problem, but in turn created its own problems requiring further intervention." As the quotation above suggests, there are certain themes that will emerge as we explore the history of America's healthcare. These themes constitute financial, ethical, and political phenomena that can be interpreted in multiple ways. I'll try to point them out as we come across them, but I certainly won't get everything. So be on the lookout for yourself for what themes pop up and emerge in the history and continuation of America's healthcare. So I'll try to do an overarching summary, and then we'll talk in more detail about each of these stages in America's healthcare. So in 1765, the first of many medical schools in America was established in Philadelphia. At the time, patients directly paid physicians out of pocket, but as the academic world grew, university-trained physicians became suspicious of untrained physicians and started lobbying for licensure requirements for all physicians and later for all medical schools. Obviously, setting a standard for medical providers is not a bad idea. However, it also kind of eliminated the competition as it raised the quality of medicine. So slowly this trend increased, leading to higher paid providers who had less competition. But this also meant that the ratio between patients and physicians decreased. So for example, in 1900, there were 175 physicians to every 100,000 people. In 1930, there were 125 physicians to every 100,000 people. And then in 2010, there were less than 90 physicians to every 100,000 people. The raised quality of providers starts to deteriorate when there are too many patients per provider. So let's back up to the 19th century. Insurance existed at this time, but like other forms of insurance, it only covered extreme circumstances. This changed during the Great Depression when no one was able to pay for any circumstances, extreme or routine. Thus, Baylor Medical School in Dallas decided to experiment with an all-inclusive form of community-rated employer-based insurance by offering all medical services to teachers in the area for an annual fee of $6. Eventually, this turned into Blue Cross Blue Shield, and it proved immensely popular until other insurance companies decided to offer lower premiums to healthy insurance holders. This is called experience rating. Of course, the healthy people who used less healthcare services bought these plans, forcing companies that used community rating to raise their prices on the remaining unhealthy individuals who used more medical services. So you can start to see how this would create a problem. During World War II, the supply of workers decreased immensely because all the healthy men went to war. So to prevent companies from competing for employees by offering outrageously high wages, the government actually froze wages. Employers then needed a new non-wage incentive for attracting employees. Therefore, they started offering benefits, which did include health insurance, to attract more employees. So the government actually really liked this, and they made benefits tax deductible, which means they saved the employer money. Of course, the practice of offering benefits has persisted long after World War II. So meanwhile, the unemployed and retired were left with expensive insurance plans, since most healthcare plans were then priced at a rate that large company employers could pay for. Therefore, Medicaid and Medicare were signed into law in 1965 as part of LBJ's Great Society. Nevertheless, many people remained uninsured, so Reagan actually signed EMTALA into law in 1986, making ERs free clinics. And even with all these measures, about 10 to 15% of the American population remained uninsured until 2010, when Obama signed into law the Patient Protection and Affordable Care Act, PPACA, or just ACA for short, while eventually reduced the amount of uninsured people in America by approximately half. So I think we went from 50 million down to 25 million uninsured. So let's slow down and digest all of that information and go into a little bit more detail. So all medicine started as a simple transaction from patient to doctor. This is called out of pocket. So sometimes this was even a barter system, and especially in rural areas, they'd give chickens or eggs or freshly baked bread in return for medical services. So I want to give you some time, just like 30 seconds or 15 if you're listening to me on double speed, to jot down some advantages and disadvantages that you can think of for paying for medicine out of pocket. So I'll go ahead and give you that 30 seconds. All right, I hope you got at least one advantage and one disadvantage written down. So here are some that the textbook and I came up with. The advantages of out-of-pocket system includes, there we go, people will know how much a visit to the doctor will cost. This is actually rarely the case right now. If you have much experience at a hospital, it's kind of mind-blowing that people would know how much it costs to go to the doctor. So that's definitely an advantage. Another advantage is that there is no inflation due to middlemen. So there's no insurance company or government staff that needs to take a cut of the money before it transfers from your hands to the provider. So it's a pretty, very simple transaction. The disadvantages are nonetheless overwhelming in many cases. So one, it's expensive. Healthcare has always been expensive because it's specialized. So not everyone can afford to pay for it out of pocket. It's also unpredictable. So an unforeseen emergency can become unaffordable very quickly. And then it's also physician driven rather than consumer driven. So patients rely on the doctor to tell them what they need to purchase. For example, early into the COVID lockdowns, one of our friends expressed that every time he sneezed, he didn't know if he needed a Claritin or to prep for an ER visit. So this is an illustration of how something a little trifle can turn into something extremely dangerous very quickly, or maybe even slowly. So think if you are a person in relative poverty, they're not going to go to the doctor to investigate their weird rash or numbness in their fingers or irregular period, even though all of these things could be manifestations of a serious condition. At the same time, they might not be anything serious at all, and it usually takes a medical provider to discern when that's the case. So all this to say, healthcare market is physician rather than consumer driven, as quoted by the textbook, and therefore a mechanism that mitigates the consequences of unforeseen events and large expenses is necessary for doctors to continue working and for patients to afford the care that they need. So in comes insurance. Specifically, individual private insurance never became a major method of paying for healthcare in America. However, it did address two of the disadvantages talked in the slide before. So expense and unpredictability, that's just what insurance tends to take care of. It tends to help make things more affordable and helps us prepare for unpredictable events. However, this never really became a major method in individual insurance because it's easier to collect insurance payments in bulk from a whole company rather than from individual people. So we quickly moved to employer-based insurance. So this started in Dallas at Baylor University Hospital during the Great Depression, and that eventually became Blue Cross Blue Shield. And there's some controversy over the motives of the physicians who started this, and there's really no way to know what their motives were, but it's good to keep in mind. Were they benevolently proactive in securing healthcare for people who could not afford it? Or were they looking for a way to guarantee that payment would be generous and that cost control would remain on the back burner? So under this first model in the 1930s, insurance was a simple annual fee of $6 offered to a group of teachers at a community rate in return for as many healthcare services as they needed that year. So this was the start of Blue Cross. So let's talk about the difference between community versus experience rating. Blue Cross was successful in between the 1930s and 70s, but in the 70s, experience rating left them with all the unhealthy policyholders, and they had to increase premiums by 100% in order to not go bankrupt. So how did it do this? Experience rating drove other insurance companies that used community rating out of business by offering lower rates for young and healthy patients. So under community rating, insurance companies offer the same price to every person or family in a particular region. The price is determined by the risk of the population or the amount of medical services the whole population is likely to purchase. That cost is then divided relatively equally among insurance members with variations according to different types of plans. So community rating, generally equal for everyone in the community. Experience rating, insurance companies are going to offer discounts and better deals for people who are relatively healthy, because it makes sense. If they're not going to use as many medical services, they shouldn't have to pay as much. So let's reflect on the fairness of insurance rating. Under a community rating, the patient with a pre-existing health condition or a disability does not have to pay more for being genetically or physiologically predisposed to costing more. So this seems pretty fair. No one can choose their genes or perfectly escape all emergency accidents that might cause permanent and expensive damage. However, there are ways to avoid getting sick, like better diets, regular exercise, not smoking, not drinking alcohol in excess, etc. So under community rating, healthy people pay more for insurance to cover the cost of people with pre-existing conditions, since they are likely to use fewer medical expenses, while the less healthy people are likely to use more medical expenses, even though they pay the same rate. So many people believe that this is not fair. So for this reason, experience rating was an attractive alternative. So I'm going to just now click on this this question. What are your thoughts? And I'll give you a little bit of time to answer this on your own. Is it fair that under community rating, people who take good care of themselves must pay higher insurance rates to cover the cost of others? Technically, it's the same insurance rate, but it's proportionally higher for them because they're not using as many services. And if you were the person with a genetic defect and you required more costs and medical expenses, would you prefer community rating or experience rating? So these are some good things to think about as we evaluate the fairness of community versus experience rating. And if you're creative, can you think of a good mix in between that might be possible? So to promote insurance, the government started cutting taxes on companies that would provide insurance for their employees. So basically, insurance benefits became non-taxable income for employees. And in essence, this basically subsidized insurance for many full-time workers in America. Offering health insurance benefits then became standard because it saved companies money by putting non-taxable money into health insurance accounts, which would have otherwise been taxed as a typical paycheck. So eventually, health insurance started covering not only emergencies, but also routine care. This is different from the typical insurance model, which only covers members from unexpected events, not for expected costs. So let's make another pros cons list. This is not, whichever has the most bullets wins. So these bullets aren't necessarily equal to each other, but they're good to keep in mind. So advantages of insurance include that it makes the unpredictability of health needs more manageable. That's pretty obvious. That's what it's designed for. It also makes healthcare more affordable. So insurance will help pay for it. So therefore, it's easier to afford. It covers routine care, which makes it different than other insurance plans, but that's an advantage in this case because it encourages regular doctor visits. So some people wouldn't go to the doctor because they can't afford it, but now their insurance company covers one annual checkup. So they're going to go for it because it's technically already included in what they're paying for. So it encourages regular doctor visits, which is a really good thing. And then lastly, it creates some form of standardization. So creating standardizing criteria for what insurance will and will not pay for indirectly makes healthcare less of a physician-driven market. This can be an advantage when it prevents doctors from making mistakes about their patients' care by neglecting best practices. On the other hand, standardization can also be a disadvantage. So when it limits the ability of patients to pay for what the doctor has determined is best if the doctor and insurance company are at odds, which does happen every now and then. So it's unfortunate if your doctor knows this is going to work well for you, but you don't technically fit the insurance criteria. So now you can't afford whatever X treatment it is. So that's a disadvantage. Another disadvantage that was also an advantage in one situation is that healthcare insurance covers routine costs. So making regular doctor visits covered by insurance also makes those regular doctor visits expensive. And this can disproportionately hurt people who don't have insurance. So the price of a regular checkup goes up because now insurance is paying for it. But then those who don't have insurance still have to pay that higher rate. So, which leads me to the last disadvantage is that insurance tends to just make healthcare more expensive because there's few cost control measures, except the fact that insurance companies need to make more from premiums than they spend on their members. So this makes the total cost of healthcare higher, even if the patient ends up paying less because insurance covers a large percentage of the higher cost. As experience rating lowered costs for healthy patients, it raised costs for unhealthy patients, which included the elderly and the poor. Furthermore, insurance companies set rates that employers can match because most people had insurance through their employer. Again, this left out people who are unemployed, which are mostly elderly and poor Americans. So to reconcile this, Medicare and Medicaid entered the stage in the 1960s. So Medicare provided health coverage for elderly citizens 65 years and older, and Medicaid provided health coverage for impoverished citizens who made only a certain percentage of the federal poverty line. This was not the first time the government had been involved in healthcare, but was certainly a major step to greater involvement and marked the beginning of government payment for privately operated healthcare. So many people welcome this step as being in line with the government's constitutional responsibility to promote the general welfare. Others did not welcome these steps because they believed the best way to promote the general welfare of the nation is to limit governmental interruption, which may throw a cork into the natural economic and academic systems, constricting doctors from doing what they think is best to doing what less medically educated government and people think is best. Nevertheless, the government decided to increase its involvement. In 1997, CHIPS was added to Medicaid to cover medical expenses of children whose parents could not afford to purchase medical insurance. And even Ronald Reagan, a conservative who would fall under the limited government category, ended up making a government mandate that reformed healthcare, which was called EMTALA. It stands for Emergency Medical Treatment and Labor Act, which, among other things, guaranteed that patients will be seen and stabilized at an emergency room, regardless of whether they could pay or not. So this quickly flooded ERs with indigent patients who could not pay, contributing to hospitals needing to overprice care for those who can pay to make up for their losses on patients who cannot pay. So again, we see the themes of people who can pay having to pay for people who can't pay. And some people question the fairness of that. So that lastly brings us to Obamacare. So just to put it into perspective, in the 1980s, the amount of uninsured people in America steadily climbed from about 25 million to 50 million in 2010 when Obama signed the ACA. The goal of the ACA was to provide universal medical coverage and control the extremely high costs of medical care, by targeting higher education students, enforcing community rating, and encouraging states to expand Medicaid. The result was an almost instant drop in the amount of uninsured people in America, not to zero, but at least back to 25 million, which was the lowest it had been since the 1980s. So to do this, the ACA required all insurance companies to abandon experience rating and reinstall community rating. It further mandated a penalty called the individual mandate for anyone who did not purchase insurance, since community rating is only sustainable if there's a large enough population of insured patients who will use very few medical expenses. So there are two ways of looking at this, and indeed they're both true sides of the same coin. On the one hand, community rating and mandates financially penalize the healthy in order to take care of the unhealthy. On the other hand, the ACA redistributed the burden of paying for the healthcare system from the poor and sick to the healthy and wealthy. So sometimes it's also good to note the ACA is confused with a single payer system, but the ACA is not a single payer system. An example of a single payer system would be the current Democrat push for Medicare for all. So in that case, there's only one option for insurance, and it's governmental. So the ACA did not do that. Instead, it mandated rules for private insurance companies and offered tax credits for certain demographics to pay for those insurance companies' plans. So we'll talk a lot more about the ACA in later presentation. So we're going to take some time to reflect on this, considering what we've learned so far. Answer some of these questions on your own. Is government intervention in healthcare a constitutional responsibility according to the preamble's phrase to promote the general welfare? So that's something to think about. Should the government be involved or should it not be involved? And then have government interventions improve the quality, cost, and accessibility of healthcare? Which ones have, which ones haven't? Have some improved the quality but not the cost? Have they improved the accessibility but not the quality? Try to think about those balances and why have they or why have they not? And then have they improved the overall health outcomes of Americans? So they might have better access to lower cost and higher quality healthcare, but is it actually making a difference? This is something to keep in mind. And was it fair to enforce a financial penalty for not buying into a system that was still too expensive for many people to afford and had other unresolved flaws? So even a lot of people who have left political ideology criticized the ACA for forcing people to buy into a system that really had not worked out all of its kinks. So there is some question about the fairness of that. In conclusion, we'll go through a little summary and then some reflection. So in summary, we went from the out-of-pocket system to employer-based private insurance to the governmental system. Healthcare and insurance developed from all of those things to now being largely government financed. So Medicare is one of the largest financial systems in our healthcare system. So government financing is the biggest contribution to healthcare financing. So that's good to keep in mind, but all of these other things still exist, even out of pocket still exists. So the elements of previous forms of payment still exist. So we're kind of like a collage of multiple ways to pay for healthcare. The quote at the beginning also serves as an adequate summary. I'll read it again. So healthcare financing in the United States evolved to its current state through a series of social interventions. Each intervention solved a problem, but in turn created its own problems requiring further intervention. So I think that's a really good summary that each intervention and payment model have their own advantages and disadvantages. We talked about a few of those. Ultimately, the solutions to America's healthcare problems and gaps in coverage vary by political ideology and systematic approach because our society doesn't quite agree on some of these fundamental premises and questions about community versus experience rating and the role of government in promoting the general welfare of the people. So I imagine if you get to talk with your classmates about some of the questions asked in here, and we'll go through a few more, you'll all have different answers, and that's okay. But it does make it hard to find a system that really works for everybody and fits everyone's priorities. So I just want to end with some reflection on the summary and on a couple of these questions. So we have covered lots of information and we'll dig even deeper into parts 2, and 3. So for now, I just want you to reflect and answer these questions on your own. Again, you probably won't be graded on your answers. That's up to Professor Clay. But as a healthcare professional, you should have some well thought out answers to these questions. So, can any intervention solve a problem without creating another? If you get to influence policy at all, this is a good one to think about. The goal is to reduce the amount of problems you create by solving other problems. And then have the interventions to the problems of out-of-pocket spending been worth the problems that they created? So we've seen some higher cost in insurance. Is that worth better affordability and access? I think most people would say yes, but you're free to answer however you'd like. And then can insurance make medicine more affordable without making it more expensive? I think this is a really key question that we need to figure out how to answer. I definitely don't have the answer to it, but maybe it's possible. Hopefully we'll find out. And is it fair for healthy people to bear the financial burden of unhealthy people? This is a good question just to keep in mind. Socially, politically, and financially, is that a good way to build our system? And then lastly, is healthcare a right or a privilege? And are these even adequate words for categorizing healthcare? So I want to encourage you to be a little bit more creative. sometimes we fall into a either or mentality, and it might be a false dilemma. So really evaluate, is right and privilege the two best words to describe healthcare, or can you think of some other ones? So I'll answer that question on my own later in some of these later presentations, but I think it's a good one for you to think about. And here are some references, and I hope you enjoyed part one of Summarizing Healthcare in America.